Hi everyone, my name is McGreevy and I'm a research assistant from the Health Economics team at King's College London, and today I'm going to be presenting on what impact the COVID-19 pandemic had on primary care consultations using evidence from the London Borough of Lambeth. So this research is part of an overarching project called Understanding Multiple Long-Term Conditions in Lambeth and Southwark, and it's funded by the Guy's and St Thomas's Trust. The aim of this research was to provide insight into the effect of the pandemic on primary care consultations, as we know that the pandemic may have affected it in several ways, including, for example, the changing the healthcare needs of patients, changing how the care was delivered, and disrupting some of the supply of the workforce. For our data source, we use the Lambeth DataNet, which includes the health records from 41 GP practices in South London. We included individuals aged 18 or over, and our timeline was February 2018 to March 2021. We defined the start of the pandemic as March 2020, and in our data it was an urban, deprived and ethnically diverse population. For our outcomes, we looked at the monthly consultation rate, and this is broken down into 3 provider types: GP, nurse and other healthcare professionals, and 4 modes of delivery: so face-to-face, telephone, home visits and electronic. And we excluded administrative consultations as they may not have reflected the healthcare needs of the patients. And for methods, we assessed the temporal trends using descriptive analysis. Just to give you a reminder of some of the key events that were affecting primary care during the pandemic, as it helps explain some of the trends we find. So at the start of March, we had primary care providers being recommended to replace face-to-face appointments with telephone and video triage. We had the first national lockdown on the 23rd of March. On the 14th of April, we had GPs informed of specific terms that could be suspended under their contracts. In mid-September, they were reminded of the importance of face-to-face appointments, as some patients had reported issues in accessing these. There were then 2 further lockdowns in November and January. The vaccination programme started in December. And specific to Lambeth was the research testing going on in February in connection with the new variant. First, we'll look at the results for total consultations. So this graph plots the monthly consultation rates adjusted for the number of registered patients, and the red dotted line is the start of the pandemic. And you can see at March 20 that consultation rates were relatively unaffected by the pandemic, but then they take a large drop in April 20, potentially because patients were deterred from contacting their practices over fear of infection or not wanting to put an extra strain on the healthcare system. So in April 20, the consultation rates were 16% lower when compared to April of the previous year. However, we then see an upward trend from this point for the rest of the period, potentially representing an increasing COVID-19 burden in the patients, and the large increase towards the end of the period might be because of the vaccination rollout or due to the surge testing that was happening in Lambeth at that time. So when we analysed the figures, consultation rates had grew by 16% between year ending March 20 and year ending March 21. We then broke this down into provider type and delivery mode, which is shown in this graph, and we found that there was a change in the composition of delivery mode, and all provider types saw an initial decrease in their face-to-face consultations in March and April 2020, but then they began to slowly recover. The top 2 lines in the graph are face-to-face, GP face-to-face and GP telephone. And you can see from April 2020 that telephone consultations become the most frequently used delivery mode for GPs, and it remains so for the rest of the pandemic period. So this chart presents the proportion of consultations by delivery mode. And so while face-to-face had made up 75% of total consultations in February 20, this had reduced to 53% in March 21, and telephone had grew to 43%. For GPs, as just mentioned, telephone consultations became the most frequently used method for GPs, and in March 21 this was 52%, and face-to-face had decreased to 45%. For nurses, due to the nature of their work, they've seen smaller changes in their composition, and face-to-face remained the most common method for them. So in March 21, 82% of their consultations were face-to-face. For other healthcare professionals, towards the end of the pandemic period, they began to use electronic more. So in March 21, 14% of their consultations were conducted electronically. This graph then shows the total by provider type. While we can see a steady upwards trend for GP and other healthcare professionals in the pandemic period, the same was not observed for nurses, and their rate remained more stable, potentially because their work is less suitable for non-face-to-face methods. And from February 2021, other healthcare professionals began delivering a larger proportion of consultations. So while in February 20, they made up 17% of the consultations, in March 21, they were delivering 21% of consultations. Finally, to highlight some of the strengths and limitations of our research. So we use a large longitudinal data set with an urban deprived and ethically diverse population. And this is important given that these groups were disproportionately affected by COVID-19. For limitations, it's possible that part of the increase in consultations that we observed could be a result of telephone consultations first being used to assess if a face-to-face one was required, and so that may have created a degree of duplication and overestimated the true healthcare demand. The duration of and rationale for the consultations were not available in the data, and so we couldn't tell if a consultation was for COVID-19 or for a pre-existing long-term condition, for example. And our research does only capture primary care, so it's also important to consider secondary and tertiary to gain a more holistic view of healthcare utilisation. So thank you for listening to my presentation. If you have any questions, please contact myself or my colleague Marina at the email addresses on this slide. And if you are interested in seeing some of the further research we've carried out in this area, Marina is presenting at the conference on the 6th of July, and this research focuses on individuals with multiple long-term conditions. Thank you very much.